seeing that, just let me know if no one can. Sam, thank you very much for the generous introduction there. I wouldn't describe myself quite as a recon surgeon yet. For those that don't know, I was fortunate enough to have an opportunity to work quite a bit with the South African doyen of reconstruction, which is Prof. Johan Modea at Easter River Hospital, where he was had a high volume urethroplasty service that I was lucky enough to join him with. And then basically as of March last year, I've taken over the services there as a sessional urologist, doing quite a bit of recon work, but some of the day-to-day stuff for the Easter River population as well. And then I do a little bit of part-time sessional work for Western Cape Rehab as well. So I took over from Prof about March last year. COVID forced him to a little bit earlier retirement than planned. And just to thank him for all the time he spent with me, but also the surgical team out there led by Carl Strauss. He manages a lot of the stuff while I'm away. And obviously the nursing team and everyone out there and the registrars that come from Cruises to give me a hand. So I must say I would have loved to regale you with hundreds of stories and great graphs and statistics about my urethroplasty cases. But unfortunately, this little guy came along this year, and unfortunately, it's put a stop to a lot of our surgical work. Elective theatres, I'm sure everyone in government and private have experienced that, was cut short pretty much at the knees. I can tell you we've probably done, I myself and the registrars, maybe Alison Moore, have probably done about 30 to 35 urethroplasty cases. We don't routinely follow them up. Unfortunately, time doesn't allow for fancy cystoscopies and flow rate follow-ups and things like that. We base our improvement in patient symptoms on what they tell us and whether they come back. That will hopefully change as we pick up our pace and find a way to kind of just balance our time at the end of the day. So I thought I would rather just give you a brief overview of the management of urethral strictures. And interesting enough, while I was researching the talk, I came across the European guidelines, which were released in 2020. I don't know how many people know that there were guidelines released, which is quite significant. It's a new guideline, first published in 2021. Prior to this, the only sort of guideline that gave you any sort of direction with the AUA. And I think those were last updated in 2017. So just to say that the panel on the guidelines did quite a lot of reviews. One of the systemic reviews they wanted to ask was what was the role of one-stage oral urethroplasty. So let me just shrink this here quickly. In the management of patients with lichen sclerosis, and a systemic review of various free graft techniques for the management of bulbar strictures. And the results were included in the study. So just regarding the etiology of urethral strictures, iatrogenic injury, injuries that are caused by medical staff, most commonly cause strictures in well-resourced countries, accounting for 32 to 79% of all strictures. Complications from transurethral catheters tend to be 11 to 16%, and that's quite significant. I know from our experience at Cruises Care, we often get calls from the trauma department to say that they've now got a catheter blown up in the bulb, or we picked that up on CT scans. And it's been well sort of documented that in a hospital patient setting, about 25% of transurethral catheters are completely unnecessary. That's important to look at. After transurethral prostate surgery, including TURPs and things like that, 4.5 to 13%, quite alarmingly high, with a bladder neck stenosis rate for the same procedures of 0.3 to 9.7%. Radical prostatectomy with viscourethral anastomosis strictures, 1 to 3%. They say urethritis due to sexually transmitted infections, predominantly gonorrhea, has dropped quite significantly in well-resourced countries. And it used to be around 40% of all cases, down to less than 1 to 3.7%. And they believe that the reason for that is promotion of safe sex practices, easy access to sexual health services, and timely treatment with antimicrobials. STIs in non-well-resourced countries tend to still account for 41.6%. And I must say, our patients that usually come and have some sort of history of a STI being treated. External trauma, the classic one being sternal injury, is the second most common cause of stricture formation in well-resourced patients or countries, where lichen sclerosis involves the urethra in 20% of cases and is the most common cause of pan-urethral stricture disease at 48.6%. Idiopathic strictures are seen in about 1/3 of all penile strictures and almost 2/3 of all bulbar strictures. When those cases are closely looked at, it's usually related to catheter-related trauma. You can have some sort of history of catheterization or instrumentation in the patients. Regarding pathophysiology, just to say there's a noxious stimulus, the epithelium is denuded, you get squamous metaplasia, fissure develops, and then you get urine extravasation. And from that urine extravasation, fibrosis develops in the corpus spongiosum, and fibrotic plaques coalesce, and then you have a stricture. So just regarding some of the definitions we should use, male urethral strictures refer to a narrow segment of the anterior urethra due to a process of fibrosis of the urethral mucosa and surrounding spongious tissue, that's spongiofibrosis. In the male posterior urethra, there is no spongiosis tissue, and this location, the term stenosis over stricture is preferred. Hiatal stenosis is generally accepted as a short narrowing of the meatus without involvement of the fossa navicularis. And in female urethral strictures, define most authors as a fixed anatomical narrowing causing reduced urethral caliber. In terms of classifications, we all know that we like to divide our urethra up into the posterior urethra and the anterior urethra and the various segments of that. The anterior urethra is usually involved in about 92% of cases of strictures, and almost half of that tends to be in the bulbar urethra. This diagram just shows that there is a caliber change in the spongiosis tissue as you go more proximally, and that becomes important in the management of strictures because that spongiosis tissue helps provide a well-vascularized bed, but also can cause a little bit of difficulties in dissection, and you need to be aware about that. The EUA guidelines have a new classification system, or it's the first time I've come across it, about whether it's a high degree or low degree strictures. And what they've essentially shown is that in a well-functioning bladder, you don't usually get symptoms unless the caliber of the urethra is less than 10 French. The average urethra is sort of diameter can vary anywhere between 17 and 20 sort of French naturally, although we all know that it can stretch to 22, 24 when we put those large three-way catheters in. And then strictures picked up that are less than 10 French tend to be, more than 10 French, tend to be findings incidentally on investigations and cystoscopy. Just a little bit of relevant anatomy before we proceed. Just to note that the male urethra is approximately over the bulbar arteries. These are all branches of the internal pudendal artery, and the distal urethra gets retrograde flow from the dorsal penile artery, which becomes quite important. Just a little diagram showing what happens if you take out both blood supplies versus one. The point is, if you take out the one, you can still get retrograde flow from the other or antegrade flow from the bulbar arteries. Not to spend too much time on this, but just to say there is a relevant anatomy. In the superficial sort of layers, not too much to worry about. As you get deeper, the things that become quite important are the bulbar arteries, and then just to be aware that the dorsal artery and nerve of the penis runs sort of laterally. I must say I don't tend to do my dissections deeper than that sort of deeper sort of fascia layers. And again, this is particularly relevant when you're doing those pelvic floor urethral injury strictures, because the bulbar artery is quite a large artery in the area. If anyone praying it during a dissection, you know, it can bleed like stink, and it's usually in a deep area that's difficult to control. Just in terms of relevant anatomy for harvesting buccal mucosa, so just be aware there are other sort of forms of grafts, including non-hair-bearing skin behind the ear. You can get grafts also on the penis from the penile skin. But generally speaking, most people use buccal mucosa, so it's quite important to know how to harvest it well. The main thing you need to be aware about is Stenson's duct. Just on the right upper corner there, you can see that the buccal mucosa is stratified squamous epithelium. It's got a thin layer of lamina propria underneath where the blood vessels are contained. And that's the principle. When you take it out, you thin it out, you try to preserve that lamina propria so that it contains the capillaries that you need to kind of for the graft to survive. I won't go too much into the technique. We do just sort of stress that you need an oral mouth gag, that we put about 20 mils of adrenaline and marcaine into the mucosa, just submucosa. It's quite important to get that right, so that you don't end up taking unnecessary amounts of muscle. And then if you're really desperate, we are seeing some redo urethroplasties. You can get some buccal from the lower lip as well. Just in terms of the workup, I'm not going to go too much into this, but just to say pretty much all roads lead to MCUG or VCUG, as the Americans like to call it. And it's the investigation of choice. Unfortunately, it's not always done to great sort of quality, both in the government and the private sector. And I must say, given the COVID restrictions, we get a lot of patients that have had MCUGs that were done last in 2019. So I sort of take a page out of Prof. Nordia's book and I sort of go in and see what's happening, and we kind of take it from there. Sometimes we get a little bit of a horrible surprise, but for the most of the time we can work our way around it. The sensitivity and specificity are as depicted, with a positive predictive value of 89% and a negative predictive value of 76%. And this is just basically a diagrammatic representation of what you might see on an MCUG. So I will be going through the guidelines. Mainly I'll be focusing on the recommendations in the interest of the time. We'll quickly glance at the levels of evidence, but just to say, performing a retrograde urethrogram together with a sort of prograde urethrogram with a suprapubic catheter is the best way to do it, and a weak sort of recommendation that a penile clamp device is probably the better way to get that retrograde one. So in terms of stricture management, I'm going to divide my talk up a little bit. So just talking a little bit about the DVIU, or the old optical urethrotomy. We'll talk a little bit about the management of penile strictures, short and long bulbar strictures, penobulbar or panurethral strictures, post-traumatic posterior urethral injuries, radiation-induced strictures during the congress that we just had, or the workshop we just had. I got some questions about that. We'll go into that, so I included that. And just to say, the guideline is quite comprehensive. It does include non-traumatic posterior urethral stenosis, talks about the visco-ureteric anastomotic strictures, radiation high energy posterior urethral strictures, bladder neck stenosis, female urethral strictures, and strictures in transgender patients. This is definitely a 2021 guideline. Those I won't be covering, but anyone who's interested in those topics, is quite extensive sort of coverage of that in the guidelines themselves. So just to say, the patency of your reconstruction is dependent on some well-held, long-standing sort of principles of wound healing, and that is that the anastomosis should be between healthy urethral ends without any tension. The graft requires a well-vascularized graft bed. If the full circumference of the urethral mucosa is destroyed, as we sometimes see, spontaneous regeneration will not take place. Contraction of fibrosis in the wound stops only after it is covered by epithelium. So, you may feel you have a long piece of buccal mucosa in there, but just remember that those do contract. Prof. Nordia was very adamant that you should be catching the very edge of those buccal mucosal grafts because of this contraction phenomenon. And all spongiofibrosis and scar tissue and posterior floor injuries must be excised. I think Kurt McCammon came out and did a urethroplasty workshop with us when I was still a reg, and he stressed that point. You've got to sit there and chip that hard tissue out before you do any sort of anastomosis. So DVIUs are something that is commonly performed as a first-line treatment. I see that in my private work. A lot of people turn to that as a first-line treatment and tend to redo it time and time again. And that's not just a South African phenomenon, that's overseas as well. So out of interest, it seems that DVIU almost remunerates just as well as a full urethroplasty. And obviously there's significant time differences between the two. So we'll talk a little bit about this and the evidence behind it. Patency rates vary considerably between 8 and 77% as a range, but the general consensus is that half of the men will suffer recurrence within 4 years, requiring further intervention. That sort of recurrence rate depends on stricture length. Obviously, the longer the stricture, the worse the outcome. The stricture caliber, obliterated lumens are obviously going to have a worse outcome than ones where the lumen is slightly open. How many previous interventions, you keep doing DVIUs, there's more spongiofibrosis, the more difficult it becomes to do the treatments. The number of strictures plays a little bit of a role. Stricture location. Interesting enough, it's always been sort of thought that introducing intermittent self-dilatation post-DVIU will reduce the stricture recurrence, and it does. And there's been a systematic review of 6 sort of randomized controlled trials that was conducted, and they showed that the recurrence rate was 43% versus 62% with and without ISD. That's for intermittent self-dilatation. So it does help, but it's not going to be the be-all and end-all of everything. Whether it's a STI-related stricture or not doesn't seem to make a difference in terms of DVIUs, whether the patient is diabetic, hypertension, obesity, smoker, the sort of cardiovascular risk factors for sort of impaired capillary flow. Doesn't make too much of a difference. Surprisingly enough, the guidelines are rather positive about a 1997 study that my Steenkamp et al. That showed, interestingly, that DVIU was equal to filiform dilatation, but the procedure modalities become less effective with increasing stricture length. They don't mention about recurrence, but it's a level 1 evidence, the only high level evidence actually that is in this study, well, until recently. So again, just to focus on the levels of evidence, it varies between level 1A and 1B. We'll just focus on the recommendations. Do not use DVIUs for penile strictures at all. It doesn't work well. Do not treat segments longer than 2 centimeters. You can do it in a short segment that doesn't have an obliterative stricture. That's a weak recommendation. And then, sorry, just another sort of thing to mention that's come up. The advent of the lasers obviously given us the option to do these DVIUs with either a hot or cold knife. There is quite a bit of evidence out there, but nothing that anyone wants to place their head on in terms of what they're going to do. It does seem just on sort of trend lines that maybe using a laser isn't such a bad idea, although bear in mind in private that would dramatically raise the cost of the procedure. Just again, we should preferably, if you're doing dilatation of the strictures, given the Steenkamp study, you should do that under visually controlled, and that would be placement of a guide wire and then dilate over that using filiforms or railroading dilators over that. And do not perform repetitive more than 2 internal urethral dilatations if a urethroplasty is a viable option, and that's a strong recommendation. In other words, if you keep banging your head and this patient keeps coming back, there's a strong recommendation. If the patient's fit and willing, he should get a urethroplasty instead. In terms of the intermittent dilatation, you can see they categorize that as 1A evidence, but the recommendations are weak. In other words, do self-dilatation, and you can include intraurethral corticosteroids, so that's topically, not intralesional, to try and stabilize the stricture. There's some evidence in the guidelines. I'll leave you to that if you want to have a look at it. So in terms of the DVI intralesional injections, the things that they've looked at are intralesional steroids. This is post-DVIU to inject mitomycin C and platelet-rich plasma. The recurrence rate had no statistical difference with steroids, but the time to recurrence was significantly longer in the steroid group, with a weighted mean difference of 4.3%. In terms of mitomycin, the recurrence rate was 10% versus 50% with and without mitomycin at 1-year follow-up. Another randomized controlled trial said 14% versus 36% with a 1-year follow-up. Of note, all were anterior strictures, and they were less than 2 centimeters with mild or no spongiofibrosis on ultrasound, and there were no significant complications in the mitomycin group that were reported. Platelet-rich plasma, they centrifuge your own sample down, and then they extract these very good growth factors, and they use that. Recurrence rates were 12% versus 44% at 2-year follow-up. Complications were not significantly different between the two groups, and all of them had only Clavian grade 1 sort of complications. So that's important to know. Those complications included urethral bleeding, hematuria, urethral pain, pelvic pain, urine leakage, and genitourinary swelling. So just in terms of what the EO guidelines have to say, we should probably not be doing these out of a trial setting, despite that the level 1A evidence is there. And, you know, it might be level 1A evidence, but there isn't a lot of it. So they obviously don't want everyone just running out there and injecting these things into the lesions that they do. So one thing I noticed also during the research is that recently there's been a flurry of new publications, 2019, 2020, 2021, on urethral strictures. There's been a lot of interest, and I assume that's why the European guidelines decided to make a guideline in 2021 for it. And one of them is a randomized controlled trial called the OPEN trial that you should probably be aware about. So it was a randomized control of repeat DVI use versus open urethroplasties. And the aim was to clarify which procedure was best in providing symptom control. It was an open label patient randomized parallel group superiority trial. And it was primarily based, so this is something we'll probably see a lot more in the literature as well, similar to your erectile dysfunction questionnaires and things like that. They have this PROM questionnaire that basically has 6 questions, and most of the symptoms are regarding to hesitancy, straining with urine post-micturition to bring in their science scores. So you'll definitely see it a little bit more often. And this is when they did it. That also include uroflows, and they looked at clinical outcomes, including adverse events, and they collected that in self-reported forms. The primary outcome was the profile on, so just to say, it's not based on necessarily on uroflows and repeat MCGs or cystoscopies. They looked at how happy the patients were and what their symptom scores were at the end of the interventions. Just to sort of say that the numbers they needed to sort of recruit were quite high, and they definitely didn't recruit all those numbers. A total of 222, 109 in the urethroplasty group, 113 in the other group. It still represents the biggest study to date, but the study was noted to be underpowered. And just in terms of some of the conclusions, both groups had similar improvement in voiding score and symptoms after intervention. However, patients undergoing urethroplasty had a 2.6 higher odds of experiencing an improvement of more than 10 mils per second in their maximum urinary flow compared to those undergoing urethrotomy. The need for re-intervention was observed more often in the DVIU group, not quite double, but almost double. And that's important to know. Just in terms of the adverse events of any type, 61 versus 26 after urethroplasty versus DVIU. So obviously more adverse events in the urethroplasty group. That makes sense. It's a bigger dissection. And in the urethroplasty group, mouth pain and wound infection were the most commonly cited sort of complications at 14.6 versus 4.9%, and that's compared to the DVI group, or the DVI group, where there was pretty much 1.7% for mouth pain and 0% for the wound infection. I mean, that makes sense. Erectile dysfunction was almost double in the urethroplasty group versus the DVI group, respectively. The dorsal nerve of the penis is obviously at risk when you do very deep dissections for your urethroplasties. I wouldn't say it's a very common sort of occurrence that we see. And serious adverse events were reported 8.5 for 8.7 after urethroplasty DVIU, respectively. So basically, the open trial conclusions, remember that this was an underpowered study, shows that either procedure is likely to improve symptoms from baseline without risking significant harms, and therefore both should be available, and the duration of this benefit is longer with the urethroplasty group. We've known that for a while. The option of using urethral stents for urethral strictures is there. Strong recommendations not to do that, please. Justin and I have been involved in some cases in George Hospital where they've put an alum stent that caused a significant amount of problems down the line. So I don't know how many people have had experience with them. I know some people who tried them a lot and have stopped them completely now for the same reasons. It can be used as a temporary restraint to stabilize the stricture. And I suppose in an elderly patient that you don't want to do a major procedure on, you could make a case to use it there, but I would think that's a patient not fit for theatre. So getting on to penile strictures. So of all the strictures, this is probably the most sort of challenging one to deal with. I had discussions with Prof. McCammon about it, and he also doesn't seem to really like the penile strictures. Just to look at the options that we have for that, and to say a staged augmentation urethroplasty. Revision rates for second stage were up to 20%. So just to say that we've seen this in our own sort of series with the penile strictures, where we've laid buckle on, reviewed the patient in 6 months' time in the clinic, and realized that there's now an hourglass deformity in our beautiful buckle onlay, and we need to redo that. So it should rather be termed a multi-stage urethroplasty, and the patients need to be warned about that. We've had a gent that we did this on. We did two buckle onlays, and at the end of the day, a year and a half down the line, he has decided to just leave it as his symptoms are fine. It doesn't bother him too much. It's an elderly guy, you know, to steal Dr. Kester's term, it looks a little bit like a spatchcock chicken, but he's got good flow and he's happy to keep it that way. And in general, reconstructive surgeons tend to favor this approach in men with more complex urethral stricture disease. Multiple ventures in the past, spongiofibrosis, require excision, and poor quality of the urethral plate are sort of determinants of the sort of success of it. So what we do is we locate the strictured segment, we excise it, try and preserve a little bit of urethral plate if there is, and we lay a buccal graft sort of onto it. We come back 6 months later, we excise the skin around it, and we tuberize epithelium over a catheter. Systematic reviews have showed the patency rates of 90%, which is pretty good at 22 months of follow-up. So single stage or augmentation urethroplasty. So you do this as a one sort of shot thing, similar to how you do buckle. Show that the overall patency rates weren't as great at 75, with the average follow-up of 32 months. So not quite the 95 we saw for the multiple stage, but it is an option if the patient's young and doesn't want to walk around with a sort of opened up wound down at the bottom. Just to say the different techniques that they've looked at: dorsal ventral, double dorsal penile skin grafts, skin flaps. Just of note, the penile grafts, the Randy flap doesn't have nearly as a good success rate, and that's important to know. Generally, what I would recommend is buckle for this. And men with long and complex strictures might not be a good candidate for that. So just keep in mind, this should only be reserved for very short strictures of the penis. This is what a Randy flap looks like. More sort of historical things. Like I said, its patency rates are quite a bit less than what we'd see for laying buckle as a two-stage, but just for the interest sort of sake. For penile strictures, there is the option of excision and anastomotic urethroplasty, and I know a lot of people are looking at me now going, what are you talking about? Was ever mentioned on a ward round that we were going to do this or even consider it? It was usually a trap Professor Lazarus set for some of our junior registrars. And historically, the sort of reason behind that, it was discouraged due to risk of chordae post-operatively and therefore penile shortening. Nevertheless, there are some studies that have, say, has been performed on highly selected patients with very short segments, less than 1 centimeter, with a 93% patency rate. Patients reported satisfactory quality of life, sexual function, and with not having any significant chordae at the end of the procedures. So just remember, it is an option instead of repeated DVIUs if it's a centimeter shorter. And obviously the risks have been discussed with the patient. You can consider this, and it can be mentioned on the ward round with some degree. So just to quickly sort of say, the levels of evidence there are not as great, ranging from 2B, 3s and 4s. Often men with a penile urethral stricture disease, augmentation urethroplasty, either a single or a multi-stage approach. Offer an interval of at least 4 to 6 months between the first stage and the second stage. Do not offer anastomotic urethroplasties in patients with more than 1 centimeter due to risk of the penile chordae. And counsel patients with penile strictures that single-stage procedures might be converted to sort of multi-stage procedures and that there might be sort of complications associated with that. Just some special mentions of lichen sclerosis. Levels of evidence are not great. Do not use genital skin and augmentation perineuritrostomy in men with lichen sclerosis related strictures, and perform single one-stage oral mucosal graft urethroplasties in the absence of adverse local conditions in men with lichen sclerosis. And these patients are difficult to treat, because when you open up their urethras, you see that what looks like lichen sclerosis extends out on the urethral plate quite far. And these don't end up being short strictures. As mentioned before, they're commonly associated with panurethral strictures. Just in terms of meatal stenosis, level of evidence not that great, but basically the go-to there should be the open UREHTROPLASTY for managing these patients. I've actually got a patient that's coming to us on Monday with a botched bush circumcision that's got quite a bad sort of meatal stenosis that we'll do this on. And the results are quite good. You might just warn them that obviously instead of a beautiful neat little meatus, they might have a little bit of a spatulated meatus at the end, and they need to be aware of that cosmetic sort of probability. So moving on to short bulbous strictures, excision and primary anastomosis. I'm going to focus a little bit on that. Dr. Moore, I see the interest of time. I'm going to speed through things a little bit here. We've got quite a lot to go through. Excision and primary anastomosis. Dr. Moore and I've had a lot of success with this lately, and Prof. Nadir used to use it often. Alice and I recently did a patient that we scoped probably 10 years after excision and primary anastomosis that Prof. Nadir had done for a short bulbous stricture, and you couldn't see anything in that urethra that had sort of shown that he had a urethroplasty before. Just to say, there's two types, with transection of the corpus spongiosum and non-transecting. The patency rates are a little bit different. Obviously, the non-transecting, you try to preserve the corpus spongiosum, and that gives you slightly superior results. And that makes sense. You've got a better sort of vascular supply to that urethra. You haven't interrupted it and produced sutures there, and it should be encouraged wherever possible. 2 comparative analyses were done, and the patency rates were obviously, again, better for the non-transecting than for the transecting, but not by much. And the transecting technique is a choice for short post-traumatic bulbous strictures with complete obliteration. Those are what we've seen in straddle injuries, where there's full sort of luminal thickness and spongiofibrosis. So that's where you should, you know, if it makes sense, if there's no spongiosum to kind of give you any blood supply, then you may as well cut it out. And then non-transecting is a better alternative for almost all other etiologies. Just in terms of complication rates, I'm going to start going through this a little bit more quickly. Just again in support of non-transecting for complication rates as well. Obviously, non-transecting will give you better ED rates. So use transecting excision urethroplastomies for short post-traumatic straddle type injuries with complete obliteration. And then, sorry, I'm just going to see if I'm getting a SMS to shut up. Okay, just for those of you who are wondering what a non-transecting looks like in the bulbar area, remember that the spongiosum is a lot thicker in the anterior sort of component in the bulbar region, so you try and dissect that off. Anyone who's done or tried to do this knows that it is quite a bloody procedure. The dissection planes aren't as obvious, so prepare for blood, but if you can preserve it, definitely do it. In terms of the longer bulbous strictures, you can do an augmented anastomotic repair. So that's basically it's reserved for those patients where the strictures are just a little bit too long, in the 2 to 4 centimeter range, for you to get tension-free excision or primary anastomosis. It can be performed for longer stricture segments where there's a sort of obliterated segment where you only augment that excised sort of obliterated segment. The patency rates vary between 91 and 92% with 12 to 28 months follow-up. Although interesting is something that Prof. Laz pointed out, 2021 systematic review published in the Brazilian Journal of Urology. It's an American study but published in the Brazilian Journal of Urology. Said that the augmented anastomosis was not as durable as reported, with intermediate follow-up, and appears to have continued deterioration with more than 100 months of follow-ups. Further prospective studies are necessary. So in these patients, if you're bordering on 3 to 4 centimeters, you should probably just go ahead and do a onlay sort of graft. So speaking about these, the free graft urethroplasties, these are for strictures not amenable to EPA. The free graft urethroplasty technique is the choice of option, and buccal mucosa is the trending one at the moment. We use that exclusively at East River. We don't use anything else. I know Prof felt the same way, and I think Kurt McCammon, I know he uses it extensively. Patency rates vary between 88 and 91% with 12 to 40 months of follow-up. Many techniques described, ventral, lateral, dorsolateral, dorsal graft, onlay. There's no high-level evidence to suggest which is better. You can pretty much use whichever. Although it does seem that the dorsal one is sort of gaining more traction. I must say we've been doing a lot more dorsals where amenable. There's a lot of time we've gone in thinking we're going to do a dorsal, and when we dissected off the spongiosum or the corporal bodies, we found that the spongious sort of fibrosis tissue there hasn't left a very well vascularized bed without a sort of chipping away segments of the corpora. So then we have to kind of revert. So just be cautious, maybe do the dissection before you make the decision, make sure you have a good graft bed. Okay, and okay, again, just to say that no big differences were seen in the beginning of the thing. I said that one of the UA panels had done a systematic review of it, and they said that there was no big differences between patency rates between the techniques. Quickly, just to say those are the different techniques. I can make my talk available for anyone who wants the slides. Longer bulbar strictures, free graft urethroplasties. You can basically use whichever technique you like. I quite like the idea of the dorsal, but you should be au fait with both if you're going to be doing it, basically because it depends on how much spongiofibrosis and how vascularized that graft bed is. Remember, you need to quilt for a dorsal onlay. You need to quilt that that sort of buccal graft onto a vascular bed, which is usually the corpora in that area. And if you haven't got good blood supply, that's obviously not going to work. Penobulbar panurethral strictures. A lot of different techniques have been described over the years. Patency rates are usually lower than with shorter reconstructions. And that's versus the 90% overall patency rates for 77. Of note, and I think everyone's aware of this, called Carney's pioneered approach, where he invaginates the penis, does almost a dorsolateral kind of dissection, and then puts long segments of buccal mucosa, basically invaginates the penis, tacks it down, pulls it back through, quilts it all the way down, and he's reported in a 2012 review of 117 men, overall patency rates at quite a long follow-up was 83%, which is pretty damn good. That's what it looks like. Be aware before everyone ventures out to do this that he is considered a very high volume center, and his team there are very au fait with this sort of procedure. I wouldn't recommend it for the average urologist. Again, levels of evidence. I'm not going to stay too much here. Just to remember that for panurethral strictures who are refusing surgery or unfit for surgery, perineuritrostomy is an option, and you know, it has good outcomes. I'm not going to focus too much on that. You can go through the guidelines if you need to. So PUFU, or post-traumatic posterior urethral stenosis, is discussed in the guidelines under urological trauma. Just to say deferred management, we're not going to get into the debate about delayed primary realignment. It's quite a lengthy debate. It's been covered quite a few times before, and it's a whole talk on its own. Just say deferred management of a pelvic floor urethral, pelvic fracture urethral injury is at its earliest 3 months after trauma. By then, the pelvic hematoma is almost always resolved. The prostate has descended into a more anatomical position, and the scar tissue is stabilized. You get obliterative and non-obliterative stenosis. Just to say, anyone that there hasn't been sort of a tented alignment, there's quite a bit of dense fibrotic tissue, which is seen as a problem. Mundy maintains that can be excised and you can deal with it at the time. He has good results with that. In terms of endolympial treatments, this is not in the initial setting, and this would be the cut to light principle, which is 3 months down the line and longer. You know, it's not encouraged. It doesn't really work. It doesn't have great patency rates, and there's a risk of creating a false passage toward the bladder base or rectum. Endolympial treatments for non-obliterative short segment stenosis. Kokani led the study there. We did cold enough cut towards light or holmium, and the patency rates were pretty good, or stricture-free rates were pretty good with that. Barbagley disputed that. He had another study that looked at I can't quite remember, there wasn't a significant number of patients, but 51% stricture-free rate at follow-up. But he didn't sort of say how long that follow-up was. So just in terms of the guidelines, do not perform endoscopic treatment for obliterative stenosis. That's a strong recommendation. You can perform one attempted endoluminal treatment for short non-obliterative stenosis. Do not perform more than two direct internal urethrotomies or dilatations for short non-obliterative recurrences. So in other words, don't keep doing it if it doesn't work the first time. Those are the recommendations. UREHTROPLASty, this is sort of the go-to thing, given the complexity and difficulty of urethroplasty and the fact that the best results are obtained at the first attempt. Obviously, there's scar tissue there. If you keep coming back, you're going to cause more scar tissue, and that's going to cause a problem. And it should preferably be done in a high volume center. It's always easy to say that word in our setting, but you must remember a lot of us, particularly in the government center, end up being the high volume centers. So it's important to tackle these cases, get your learning curve, try to keep your skills up and do them. Deferred perineal excision of primary anastomosis, standard treatment for an obliterative stenosis of a non-obliterative stenosis where the first attempt has failed or after failed endoscopic treatment. The overall patency rate of this procedure is about 85.7%, so not bad. It's very important for complete excision of the scar tissue, and this is the strongest predictor of recurrence rate, and not the number of sutures that you put in to secure that anastomosis. You need to get that scar tissue out. Of quite importance, Gomez et al. Described a bulbar artery sparing excision of primary anastomosis, and that has superior sort of patency rates or stricture-free rates at quite a lengthy follow-up. I mean, that makes sense. The problem is anyone who's ever done this dissection knows that you get pretty deep at one stage, and to mobilize that urethra enough, you almost invariably prang that bulbar artery, and this would be basically meticulous sort of dissection. Prof. Nordia used to like to stick a pair of sort of dissecting scissors down into those gaps where the bulbar arteries are, and then extend the scissors and pull them out. I must have seen a lot of bleeding with that, much to Dr. Dewar's sort of dismay. I like to use good old FODAD, so that's a finger of death and destruction, and I find that that opens up that area quite nicely. Finger on either side of the urethra and then cut in between. I haven't done a lot of these in my experience, but it seems to get a better result in the scissors. We all know about gaining extra length, mobilizing corpus spongiosum, separation of corporal bodies, inferior pubectomy, corporal rerouting. These all gain you about 1 or 2 centimeters, and total pubectomy. Just of note, in the 2021 guidelines, they don't promote total pubectomy. Again, in the interest of time, you can go through this a little bit later, but just to say, there's in the middle of the section, they do not perform total pubectomy during abdominal perineal resection. The levels of evidence on the side, again, not phenomenal levels of evidence. We have to go on what we can do, and that's where the recommendations are probably more important than the levels of evidence, because these are high volume sort of surgeons that give their expertise and give anecdotal sort of advice about how to do these procedures. I add radiation-induced urethral strictures. I think we're running a little bit out of time. It's almost 8:30, so I'm going to go through this a little bit quickly. The main slide I want to get to at the end of the day is this one. In conclusion, you can look at a urethral stricture. You need to do an MCG and know the length of it. If it's less than 1 to 2 centimeters, you can do a single attempt at endoscopic management. That's assuming that there isn't significant spongiofibrosis, no fistulas, no diverticular. This can be a dilatation with a balloon or serodilators, hot knife or cold knife DVIUs, and then self-catheterization will improve the rates afterwards. However, in patients who do better with urethroplasties are ones that are more than 2 centimeters long, obliterated lumens, posterior or pendulous sort of strictures. We've already said that DVIU should not be offered in the penile urethra. once you get to there, you need to know whether the patient's fit and interested in the surgery. If he isn't, then you can look at a suprapubic catheter for the rest of his life, perineuritrostomy, or a urinary diversion. If you go to urethroplasty, you need to divide up where your stricture is in the anterior urethra or the posterior urethra. Meatal strictures we said in meatoplasty. Pendus urethral strictures we said either a staged or a one-stage, preferably probably the stage that gives you superior results, particularly in unexperienced hands. And then for the bulbar strictures, you divide them up into length. I very much like the excision and primary anastomosis. Remember, there's a transecting and a non-transecting one. And then for the longer ones, you should probably be doing buccal grafts on those. And then for the posterior, we talked about this dilatation of that area is an option, or the gold sustainably anastomotic urethroplasty. This is some of the work we've been doing. Beautiful buccal graft. This is Dr. Moore and I operating on quite a lengthy stricture. I think it was about 2 to 3 centimeters. Something that I have taken to doing sort of is only not doing inverted U incisions. I rarely do a Mercedes incision. Usually I can find that even for the very sort of posterior strictures, I can do a linear incision. And that definitely improves bleeding and sort of sepsis rates afterwards, I feel. And then at the end of pretty much all my perineal dissections, I put what has been affectionately termed the Easter River sort of mankini. And I'd use elastoplast to sort of provide good pressure onto that perineal area. The patients usually spend the night with us at Easter River and go home the next morning. They usually go into a hot shower and take the elastoplast off. Obviously, you can see this guy's going to be in a little bit of pain with all that hair, but the hot water in the shower does make a difference with that. And from what I'm hearing from the follow-ups of my patients at wound sepsis doesn't seem to be a major issue, which is great because there's nothing worse than an infected sort of perineal wound after urethroplasty. And I thank you for your attention. Sorry for taking so long.
Simon, thank you so much for such an excellent comprehensive talk on urethroplasty. I think you've highlighted a few things I was going to ask you. I mean, you did mention the role of ultrasound in assessing strictures. Like you mentioned, I mean, guys with spongial fibrosis technically shouldn't be getting an optical. Yeah. And again, I spent some time as well with Professor Dier, our urethroplasty expert, in fact, recon expert. So I never saw any excision and primary anastomosis, and probably because of the actual facts that you mentioned, that is probably only almost reserved for guys with post-traumatic urethroplasty, like a straddle injury. Never saw a single one in my time. But I mean, obviously, I've seen a few at Grooteskier, and thank you so much for actually taking on this, you know, this job of carrying on with urethroplasty work, and because we all know that it does provide an excellent exposure to our registrars. And I see Dr. Moore is got a hand up. Alison, any questions, comments?
Just a comment, Sam. Simon, yeah, just congratulations on the service that you are providing there. I think the comment I want to make is just that having the opportunity to set up centers where a procedure becomes a high volume procedure in that center is hugely beneficial. It's benefiting the patients and it benefits the trainees. And I've certainly benefited in an enormous way from the work that Simon is doing at Easter River Hospital. And just to say that I've been doing the follow-up on most of the patients over the last 6-7 months, and I can definitely support at least what Simon has said, that the patients are very happy with their outcomes thus far. And unfortunately, we don't have numbers to prove the flows, but yeah, just again to say congratulations to Sam, and thank you to the kind of coordinated kind of efforts of the Cape Metro and Tygerberg and UCT to allow for Easter River to be an ongoing service that kind of performs there.
Thank you. Any other questions on the floor? Not seeing any other question. In the absence of questions, thank you so much, Simon, for taking up some time off your private practice and sharing us this experience and a great talk. Yeah, I guess I heard you were saying your slides are available if the guys need your slides. Okay, thanks so much, everyone. We'll see you guys in the next week.